Welcome to Mastering and Guideline in Ultrasound and Echo.
Hi everyone. In this clip, I'm going to represent two cases related to the ICD and pacemaker complication, the most important complication of this type of the device, and what we have to think and be aware of that when we are scanning this group of the patient. First, we have a patient 72 years old that has 2 weeks ago had ICD and came with the shortness of breath and a little chest pain. And the doctor request for the echo. Here we can see those clips related to this study. Here we can see the lead of the page, ICD, and beside of except those other view and study that we do in a regular echocardiography, uh, means those valvular valve motion and everything. What view and what approach in this case has been missed? In other words, what we have to show here in this case that it's missing related to the ICD. Now let's go to the next case. Here we have a second case that is a 68 years old man. They put, for some reason, they put a temporary pacemaker. And patient, after insertion of the pacemaker on the floor, complain about some chest discomfortable and close kind of the pain and more discomfortable that a little with breathing it become worse. And the doctor request for the echo and we got it these images. And here we cannot see in those clips that we can see the pacemaker lead. We cannot see. What is the best view for the finding, in this case, the lead and location of the pacemaker, and what we have to do on this case? Now, let's go to the explanation. Before I go to explain those two cases, first I like to give a short review for these topics. As you know, one of the best technique for long-term management of the arrhythmia are implantable electronic device that they are divided into two groups, pacemaker and ICD or implantable cardioverter defibrillator. Beside of the little structural difference like that in the defibrillator or ICD, the case of pacer is a little bigger and software is a little different. Generally, they are very similar. Some of depending of the type and method we use it. Each of them can have one wire or two wire or three wires. Three wires used for resynchronization that one goes, two leads goes to the right and left ventricle and one in the right atrium. The other has usually most of them they have two wires. One goes to the right atrium, almost in the appendage, right atrial appendage, and the second one somewhere between the apex to the mid maximum one third of the interventricular septum at the right ventricle side. Anchor the tip of the electrode to the myocardium. In from that aspect, there are two type of the anchoring or implantation of the tip of the wire to the myocardium. One type is active that has those has a spring and tip of them that go embedded inside of the myocardium, 1 to 2 millimeters, sometimes 3 millimeter inside of the myocardium. And the passive type has some kind of hook or tine that anchor between the trabecula and the right ventricle. So there are two types that implant or anchor inside of that. We have to keep in our mind that that anchoring usually doesn't penetrate because of the structure and the shape of the tip, but the active type of implantation it embedded and the risk of perforation in this type is more. Beside of that, we have other type of the ICD that is leadless or wireless that in next slide I'm going to show. Here is the type of the different type of the ICD and pacemaker, the shape and size. You can see here we have those two type of the active implantation that spring or coil goes inside of the myocardium, and this one type, in this case, is leadless or wireless of the ICD that has some hook or arms that goes between the trabecula and established in that area without penetration inside of the myocardium. All those IED or ICD and pacemaker, they are opaque. We can see in the X-ray, but nowadays they, especially in this subcutaneous that I'm going to explain, they are compatible with MRI, especially the last few years. It has been designed and even they can use it. Before I go more forward, I have to mention we have two types nowadays. From the beginning of the pacemaker and ICD, almost it has been past 50 years. But recently, during last 15 years, there are some invention for the subcutaneous ICD that in the transvenous ICD they will implant the pacer on their usually left side, sometimes right side, but most of the time on the left side, subcutaneous or submuscular pectoral muscle. The lead wire passes through the subclavian vein and finally goes to the right side of the heart, or from the other side, from right subclavian, and goes to the right ventricle. Rarely they use the jugular vein for this purpose. For the subcutaneous ICD, that 80 to 90% of the patient can be candidate for this type. The good things is has those complications with the transvenous ICD almost 90% decrease because we don't go inside of the heart. It implant close to the armpit between the pectoralis muscle and latissimus muscle, and the wire goes under subcutaneous and electrode will be implanted under subcutaneous next to the sternum. This type is more recently more being used, and especially for young people has much better result and less complication, even in those cases that they have some risk factor for infection, or like those immunosuppressive dialysis patient, or they have history of the infection, intracardiac device or rupture, or there is any other contraindication or risk factor for intracardiac, we can use subcutaneous ICD replaced for the transvenous. Here, as you can see, this is a wireless or a leadless ICD that goes and anchor to the trabecular you can see, and this one is the active implantation that screw inside of the myocardium. The most important things about this type is penetration. As you know, the location for the tip of the implanting and anchoring the tip of the lead or wire is somewhere between apex of the right ventricle to this one third or even sometimes a little more proximal of the interventricular septum. And when we are scanning those patients, especially those patients that we are suspicious about complication of the uh, ICD or pacemaker implantation, especially after implantation or a few weeks after that, we have to find exactly where is the tip of the wire or electrode, where is exactly is implanted. In patient with ICD or pacemaker, we have to keep in our mind three major complications of the this device. First, penetration or perforation of the myocardium. Second, infection, and third is fraction of the lead. Most of the time, apical four-chamber plaques and PSACs and subcostal, we can see those lead and wire very easily. For example, in this case, we have dual chamber leads that you can see one the atrial and another ventricle. And if we try to open up the tip of the lead or wire, that is we can see it and we can approach it, see where is exactly the lead has been anchored. If we cannot see, for example, in this case, the end of the tip, just move a little medial, a little higher and medial from forechamber to the medial off axis and fanning to the left of the patient with sweeping up and down, we can find exactly the tip of the wire where is penetrate there and anchor and attach to the myocardium. So any spot from the tip to the here will be depending of the cases where they want to put it because there are little differences. I'm not going to talk about that. So we have to search the tip where is anchored and attached to the myocardium. Now let's see for those two cases. Here, our first case, as you can see, on here, the first thing that come to our mind, there is some pericardial effusion that we can see on the plaques. Here, PSACs a little at this view and this view. Beside of those, the regular view and study, we have to keep in our mind is that any complication at top of them is perforation and we have to look for pericardial effusion. On this view, we can see there are three important findings that make suspicious there is something going on. First of all, we can see better pericardial effusion. Here, a pocket of the pericardial effusion. Second, as you can see, the wire or electrode, instead of the directing toward the septum, is directed to the free wall. That is another finding that make us thinking what is going on, there is something wrong. And the third one, we have to find exactly where is the tip anchoring to the myocardium. So for that purpose, we have to go in different off-axis view. Especially in these cases, medial off-axis is very important. How? Let's go there. For that purpose, when we founded the wire, we go and if we saw it in apical, four chamber or RV focus through or medial, we have to fan up and down and follow the lead. If we cannot see the tip of the lead, we can move the medial a little higher or lower during that time, following the wire and twisting clockwise or counterclockwise, and meanwhile a little fan up or down slowly, and follow chasing the wire until we can see the tip of the electrode. At this case, you can see we are off axis. We don't see anything else, just right ventricle and pericardial effusion, but we can see tip suddenly at this specific view because patient breathing, it goes and penetrate inside of right ventricle free wall, even penetrate the pericardial fat pad, and even sometimes touch the pleural. That is the reason this patient has sometimes pain with the deep breathing sometimes. And still, we can find it better view with the just twisting clockwise or counterclockwise, a little fanning up and down. We can open up completely the wire if we are in the right angle. Then we can see exactly here. You can see completely perforate the free wall onto the outside. We put color for seeing there is not any active bleeding. Even if there is active bleeding, usually we will see during study the size of pericardial effusion increased more. Here you can see it. I just mentioned here this ICD is biventricular ICD for resynchronization, that they have three wire, one in the right appendage, right ventricle, and another to the left ventricle. This patient went through CAT and relocate successfully. Transvenous temporary pacemaker almost is universal imposed TAVR. Almost most center they put a temporary pacemaker, or any situation bradycardia that patient had during OR. Usually, a temporary transvenous pacemaker is a choice. This pacemaker has one lead, and there are different type of the tip of the pacemaker, temporary pacemaker. Some of them are blunt and round. Some of them are a little pinpoint, and the thickness of tip is about 1 to 2 millimeter. So it can, and we have to remember that the right ventricle free wall is very thin. Some spot 2, 3 millimeters, or sometimes 2 millimeter thin, especially close to the apex. And the temporary pacemaker will be anchored and placed at the tip of the right ventricle, exactly at this spot. And for when we scan those patients, we have to find and go off axis, especially medial off axis. This view is much better for checking that the apex of the uh, right ventricle. Even in this case, it looks like the patient has some McConnell sign, but it's not. I explained in another lecture. Can go and see how we can differentiate it. Anyway, in this case, we cannot see the wire of the pacemaker. What we have to do? It doesn't disappear or anything. The best view for the temporary pacemaker, most of the time we can see in the one of those view the pacemaker wire very easy. But in some cases, depending of the orientation and body habit, orientation of the heart and body habits of the patient, and the timing of the putting the pacemaker electrodes, sometimes is very off, is more anterior or more posterior. You have to think about the apex 3 dimension. So it can be completely basal view or anterior view, and you can see it. For temporary pacemaker that has one lead and small, and we don't anchor it, just we fix it at the contact to the apex, is subcostal view. If we couldn't see any on any of those parasternal or apical window, off axis, anything, we have to go and search within the subcostal. Here in subcostal view, we could check the lead and see what is going on. And as you can see here, this is off axis, long axis, between 4 and 5, and kind of short axis, combination of them. So it's not in the regular classic view. So you have to be flexible, twisting, fanning, sweeping, until you found it, and chasing the wire until you see the tip. As you can see, tip penetrate completely through the right ventricular free wall, close to the 1/3 of the apex, and with the color and everything evened out. The patient didn't have any pericardial effusion, so it went and withdraw successfully in cath lab, and patient was stable. So general point for this presentation is that if you are not looking actively for whatever you are going to find it, you will miss it very easy. Always you have to be attentive and flexible, not rely on those classic view. Always go survey that region, the interest area, 100%, you will not miss anything. I hope it was useful. Up to the next time. Have a wonderful time.
Everything in this world is temporary. Life changes, people come and go, and seasons never last. Always remember that your present situation is not your final destination. Everything in this world is temporary. Life changes, people come and go, and seasons never last. Always remember that your present situation is not your final destination.